Dr. Adnan Khan is one of our faculty member in the Department of Mathematics, and he's going to discuss about modeling the transmission of COVID-19, a topic which is very much related to everyone. Either you belong to math or not, but the transmission of COVID is one of the hot topics in the recent sciences and recent research. And Adnan will be discussing about the good, the bad, the ugly. So let me just tell you that Adnan is a very, very exciting speaker. And many years back, we first encountered where I was just a participant and he was discussing about a zombies breakout. So he is very good at picking the topics which can attract any sort of audience. So I still remember that I traveled from ComSets to UET all the way 30 kilometers to just attend that particular talk, but it wasn't a waste because it was fun filled talk, and he's too good with explaining the mathematical modeling. From this talk, I can bet that the one thing you will learn how to make models, and Adnan is very good at making models through very simple looking discussion manner. But just warn you, the complexity of solving the modeling is not as simple as Adnan explains. So over to you, Adnan.
Thank you very much, Imran. First of all, apologies to everyone. My voice is raspy, and I was telling Imran that I have a COVID-like illness. Thankfully, not COVID, so I have the flu. So you'd have to bear with that. And secondly, Imran might have oversold me, so now I'm under a lot of pressure. So thank you for that, Imran. All right. So first to the title of the talk. Whenever there's an epidemic of any sort, and especially a pandemic, epidemiologists have their own modeling techniques. I'll discuss some of those. And then applied math people, they have they have their own repertoire of techniques which they use to model transmission of various infectious diseases. And so it was with COVID as well. By the way, the good teams are those which include epidemiologists who understand disease dynamics from say a physician's point of view or a biological perspective, and applied math people. So teams that combine the two do good work. And as you will see, there are teams which involve very, very smart people like physicists working in, say, high energy and stuff like that, really difficult topics, but whose understanding of the biology is not that good. And then the results they give, that's the ugly part. The bad part is what the applied math people do by themselves. The good part is when teams combine together. So that's the good, bad, and the ugly. And with COVID, it was the same thing. As I will first, so let me just give you an overview of what I'll do. I'll give you a very short crash course in what kind of techniques are used and are out there to model transmission of various infectious diseases. Then I'll show you a few models of COVID-19, one of which was done by our group at LUMS. And then there are other models. We do not claim to be the good, by the way. There's a model which was very good. Then we were perhaps in the middle part. And then there was a model developed by Imperial College London, which was basically projecting a catastrophe. And then thankfully it didn't turn out to be so. And please do feel free to stop me and ask me questions if something doesn't make sense, which it might not most of the time when I talk. So I'd be happy to answer. Okay, so what are epidemics? So epidemics are diseases in which the infected numbers, so if you have some infected introduced into a population, say a bat bites man and starts COVID, or as with AIDS, it was suspected that it was transferred by the green monkey. That's a kind of a monkey in Africa. And that's where the case 0 started. So diseases which are harmful to one species may not be harmful to another. So bats might be perfectly happy with COVID, I don't know. But then when it came to human beings, it was a catastrophe for us. Similarly, there are diseases which are not too bad for us, but in say poultry, they are devastating. So that's how things go. So epidemics are whenever you have some initial number of infecteds that come into a population, and then the infected numbers grow. That's when you have an epidemic. Mathematical models are used to, well, they're used to understand what's happening, how severe it is. They're used to make predictions, and they're also used to see, well, what happened last year? There was an epidemic. Can we make a model and see what happened there and maybe be prepared for next year? So there are statistical models. These models basically do not incorporate dynamics of the disease, but they take data and they look at trends in that data. And I'll talk about it on the next slide a little bit. Then there are mechanistic models, which is how I am able to put food on the table, because that's what I do. And here we actually incorporate mechanics of the transmission. And I'll demystify what mechanics of transmission means. You could have stochastic models in which you truly take a probabilistic approach, and then you look at many runs or simulations and look at averages. That's what the scenario analysis would look like for a stochastic model. Deterministic models are ODE, PDE based models or difference equations based models. There's another thing, as I said, you could look at last year's breakout and then be prepared for this year, assuming that the outbreak would be similar. Okay, and then that's what we did. For example, in 2011, there was a dengue outbreak in Lahore, pretty bad. So we worked with the Punjab disaster management people, and we told them, if you do this, this, and this, and I'll elaborate on this in just a bit. What are the control measures? So that or how bad could it get? Things like that. Okay, that's the retrospective analysis. You look at a past outbreak, and then the reason to do that is to see how bad it was, and if it happens again in the same way, how can you be prepped for it? So the modeling approaches, as I said, were statistical models. This is where you do time series analysis. So you could look at trends in the disease. For example, in dengue, it has been observed that there's a very strong 2-year outbreak. So if it happened in 2011, then in 13, it's expected to spike. And in 15, it's going to spike again. Remember, in this, and this was done for other countries like Thailand and Sri Lanka, where dengue has been around for a while. This does not take into account or answer the question, why is there a 2-year spike? It just says there is a 2-year spike, right? So these, as I said, they find trends in available data. They do not explain why those trends are there. Then there are stochastic models. These could be Markov chain models or SDE models. And Markov chain models are pretty popular. We have done some work with them. And it turns out that for Markov chain models, at least, in the large population limit, if the number of people in a population is very large, the results of a Markov chain or a Markov model converge to a deterministic model if everything is done carefully. Then there are deterministic models. These are the PD, OD type models. Then you could use difference equations in which time is also discrete. And then, delay differential equations, and then there's this weird thing, a phenomenological model. It's a mouthful. So these are models in which you don't, again, take into account any mechanics of how the disease is spreading. You say, you know what? Initially, every disease, which is an epidemic, grows exponentially. All I want to do is find the that R in the exponential. Okay, so that would give me how fast the disease is spreading. Again, the phenomenological models just model the disease as a phenomenon. They don't take into account the mechanics of what's happening. Okay. So as I'll get to COVID soon, okay? But I want to lay the foundation, so at least there's an overview of what's out there. So this is a statistical model. You've seen regression models. So all you do is take one variable and say, well, here is one or more explanatory variables. The value of this particular variable depends upon these other variables. And then you try to find out how they're linked to each other, okay? Take X to be the number of infected, okay? So for example, there's this auto-regressive moving average model that the value of infected now depends upon the average value of infected plus how many people were infected over the past 7 days. You've been doing this 7-day moving average window kind of a thing. You've seen a lot of reports on that, okay? Again, there is no dynamics of the disease here. There's no mention of asymptomatics, no mention of comorbidities, nothing. You don't hear terms like that, right? Because these models do not account for any internal disease dynamic. This is another model which is very popular, by the way, in epidemiology, especially with epidemiologists. This is called the time series SIR model. It's a time series analog of what we will see as the SIR model. And again, it's just relating infected to people. S is number of people who could fall ill in a population, and N is the total number of people in a population. So I want you to take away is not any details. Of course, in 2 minutes, I can't give you the details. Maybe I can't give you the details at all, but at least I can't do it in 2 minutes for sure. I just want you to see that in statistical models, you just take a variable and look at its dependence on other variables, and you don't have any mechanisms. Okay, why does it depend upon these things? For example, one thing with malaria models like these would be temperature dependence, right? Malaria somehow depends upon the temperature because mosquito survival depends upon the temperature. But in the model, we are not saying what process led the number of infected with malaria to depend upon the temperature. So that's what a statistical model does. Then there are the phenomenological models. I always find it hard to say this. It's a mouthful. So exponential growth. In the initial phase of the disease, it's been posited that many epidemics are exponential in growth, right? So you have some initial number of infected, and then it's growing at some rate R. So you want to fit your data to an exponential curve, get R out of it essentially. And R, the bigger the R is, the faster your epidemic is growing. You could, people have posited, well, this epidemic is not quite growing as an exponential now, but it had an exponential phase. Now it's flattening out. That's captured by a logistic growth model. And you want to estimate parameters K and R, and so on and so forth. So again, these models also do not take into account dynamics of how disease is being spread. It says the disease curve looks like this. It's like an exponential, it's like a logistic curve, and I will fit the right logistic curve to it. And for COVID, all the models which came out in March of 2020, I think, were more, well, all the ones I had seen were phenomenological. And then by the end of March and early April, you saw mechanistic models, which I will now go to. I sometimes feel like I'm a shell. I talk too fast, and then, like the used car salesman. So if you have questions, please ask, okay? So why dynamic models, right? So why would you want to include these mechanisms of transmission and look at those? One thing is which became very clear in COVID was we wanted to know whether or not to quarantine and isolate. It became a big political issue as well. It was a social issue, also social distancing. No crowds allowed, no indoor dining, etc., etc. So these are important questions because unless you have clear answers, you see that people are really divided on these issues. Even now, masking is, I don't see a lot of people masking, by the way, here. And even in Western countries, which are supposedly where there's more access to information, masking has become this big wedge issue of sorts. So models could actually provide support to these things by projecting different outcomes, by looking at scenarios that if you didn't mask, this would happen, if you mask, this would happen. And we will see that this was done in a nice way by a group at Arizona State early on. Again, quarantines became an issue. It's an economic issue. If you quarantine means that people who can fall ill, the susceptible population, are basically locked down. They can't leave their houses, okay? Isolation is when ill people are sort of locked down in hospitals and so on. So quarantines have a lot of economic cost. You can't go out to work. How do you eat, right? When vaccines became available, initially the supply was small. So who should be vaccinated? Frontline workers, people who are very susceptible. And does it make sense to vaccinate people who are very susceptible, who will or have comorbidities? Who should get the vaccinations, right? So by looking at different scenarios, we could answer these questions, or at least give the public health authorities some some kind of a support for their position. Wildlife and domestic animals. So it's not important for COVID, although there's this idea that COVID did start from a bat, right? But in other diseases like the Congo Crimean hemorrhagic fever, which by the way came to Pakistan a few years back, and around Bakr Eid, when we have that animal sacrifice, and the problem was that in a lot of domesticated animals, they were carrying the Congo fever virus, and so when such things happen, sometimes a lot of these animals are killed, and then their bodies are disposed of properly, so they can't transmit the disease to humans. This happened in the swine flu. Lots of pigs were killed. Similarly, with avian flu, lots of birds carrying the diseases were killed, and so on. And then another big question is, how many people are likely to be infected? You want to know how ready should your hospitals be. Do you have enough hospital facilities or isolation facilities? How many people are going to die from the disease? That's a disease mortality is important for to know socially as well, right? So these are the kind of questions which these dynamic models will allow you to answer. So my own bread and butter, this is how I make my living, is this SIR model. This is also the bread and butter of about another 1,000 academicians all over the world. It's an old model. It's a very simple idea. And it was presented back in the early 20th century by Kermick and McKendrick. It's also called the Kermick-McKendrick model. And it just says that, take a population, suppose all the students at LUMS, we lock down LUMS. So the population is self-contained. Nobody goes in, nobody comes in, nobody goes out. And then we put everybody in a big drum and roll them. So everybody's thoroughly mixed. It's a well-mixed population. Usually that's not true. People are concentrated in the dorms. People are concentrated at the COCA, and there's nobody at the football field playing, unfortunately. But this model is an ODE model, so we don't take space into consideration. We consider that everybody's thoroughly mixed. So the population is homogeneous that way. We don't take into account that the disease is more harmful to older or younger people. There's no age structure, if you will. Similarly, men and women are not differentiated. There's no sex structure here either, right? So it's just one happy, big population, thoroughly mixed. Then there are people who are ill. So you start with some number of infected, and then they somehow infect others, and then the epidemic grows. And then there's a removed population. These are people who have either recovered and are now immune to the disease. In the SIR model, it is assumed that once you fall ill, you are immune to the disease. And these are also people who have natural immunity to the disease, okay? So that's the setup. Now you could immediately ask a lot of questions and critique the model, all of which would probably be very genuine questions and critiques. But this is a base case to start with. And then we build upon it to include all your concerns, right? Well, what about vaccinated people? What about people who are latent, who are ill but not infectious, and so on and so forth, right? So these models could be, this basic model is improved upon, which we will see. This is the schematic of the model. So they're the susceptibles at some rate. So the susceptible meets infected, infected sneezes on susceptible, susceptible can fall ill. It's not essential, but there's a probability, right? And then you become an infected. Then in the case, for example, in the flu, on the average, it takes 7 days to recover. So at some rate, which is this 1/7, for example, for the flu, you recover, and then you're immune. So with the seasonal flu, once you get the flu in a flu season, you are immune to it for that season at least, okay? So this is what I just said. Susceptibles become infected upon come in contact with infecteds. Each infected meets a fixed number R of the susceptibles per day, and spreads the disease. This R contains the average number of meetings and also the probability that each meeting will cause an infection, okay? And then infected individuals recover at a rate A, where 1/rate A is the average recovery time. As I said, for the flu, it's like 7 days. For COVID, and again, the strange part, or the, well, fascinating in a way and perplexing in another, is that these parameters, these A of a disease are not known exactly. For example, for COVID, it's 2 to 14 days. A is 1/A is between 2 and 14. I mean, that's an order of magnitude difference, right? There are some assumptions this model made. As I said, it's a very simplified model. That there is the incubation period is ignored. Remember, when you first contract many diseases, the disease is in your body, but you're not infectious yet, okay? You can't transmit it. It is after a while that you are able to transmit. Populations are well mixed. Everybody's well rolled in a drum. And there's nobody coming into LUMS or leaving LUMS. This is like last year when we had closed the gates. So LUMS is a self-contained community, okay? These are the equations, very simple equations. S, of course, is a decreasing function in this model because there's no one coming in, and S is, the only thing S can do is fall ill. So if S falls ill, S gets smaller. The I compartment, or the I group of people, infected people, they grow at this rate. So anybody moving from S goes into I, and then they leave I at the rate A, and then they're removed. Okay, there's some initial susceptibles, there's some initial infected. S0 plus I0 is the total population at any time, right? S plus I plus R is a constant. As if you just add these three, you get a constant, which means that S plus I plus R is fixed in time. especially add 0. This is S naught plus I naught. So S naught plus I naught is the total number, and that just remains fixed. It's like LUMS में सबको बंद कर दिया, so nobody can escape LUMS. So that's why you're all fixed there. Okay. Okay, so what kind of questions can we ask? I will move to COVID, by the way, in like 5-6 minutes. So there is COVID coming as well. The kind of questions you could ask is, will an epidemic occur? What is an epidemic? That if there were 3 people who were infected to begin with, then you had 4, 5, 6, 7, 8 people in time, over time, who got infected before the infected numbers fell by and by. If an epidemic occurs, how severe will it be? So, for example, how fast is it spreading is one measure, or you could ask, what's the maximum number of infected that would be there at any time? Would the disease die out or persist? So, for example, flu is persistent or endemic in the population. There's always flu around. There are times when flu peaks, right? In winter, flu peaks. And surprising thing, which was surprising to me when I found out, what was that, flu has been around and studied for a few hundred years now. There's records of flu. And nobody really understands, there's no consensus on why flu peaks during the cold season. So that's something to think about. I mean, there are many theories, but there's no consensus. But in any case, so disease may die out, like thankfully smallpox died out in the human population. We have no smallpox. So people who are old like me have a big mark on our arm, a big inoculation mark for smallpox. Most of the younger people here will not have that because smallpox is no longer in the human population. On the other hand, flu is what's called endemic. It's always around. Okay. All right. And we could also ask how many people will get infected over the course of the infection. So this is just what I said, that an epidemic occurs if I naught you have some initial number of infected and that number grows. So given some rate R, S naught and I naught, and a recovery rate A, we could ask the question, what does the SIR model say that, and when will an epidemic occur? Mathematically, when is I of t greater than I naught at any time? Okay, that's what an epidemic means, that I of t is greater than the initial number of infected. So this is the I equation, and at time t, it's just this equation. Now, if I were to ask you, I want I to grow, I want I to become greater than I naught, right? So I want di dt at time 0 to be a positive number. Well, this is always positive, the number of infected. So the only thing which we need to ensure is positive is what's in the brackets, right? Whenever this is positive, di dt at time 0 will be positive and you will have an epidemic, right? So S naught needs to be, R S naught needs to be greater than A, which means S naught needs to be greater than A upon R, okay? All right, so here's the other way to look at it, is that S is always a decreasing function because it's S and I are always positive. They are numbers. R is a rate, which is always positive. So S is always less than S naught, right? And so if S naught were less than A upon R, if S naught at time 0, S naught is less than A upon R, then this quantity is negative and di dt is negative. So you will not have an epidemic. I hope I'm not going too fast. It's a mouthful. That's it. The idea is very simple, but here's the condition. We saw that if S naught was greater than A upon R, then we have an epidemic, and from that was the previous slide. And in this slide, we saw that if S naught was less than A upon R, then this derivative is negative, which means initially I will start declining. Okay. So this is a very interesting thing to see. Just forget all the math. What does an epidemic depend on? Does it depend upon the initial number of infected people? No, it seems that it depends upon A and R and the initial number of susceptible people. That's pretty odd, right? And then the reason perhaps to think about is, if there were lots of people who could fall ill, then on these chance contacts, one of them or more will fall ill. If the number of initial people who could fall ill was small, then the chances of people who are falling ill versus those who are recovering because their disease time has elapsed is smaller, and then that it dies out. That's one way to think about it. But it's interesting to note that somehow this the disease dying or becoming an epidemic depends upon the initial number of susceptibles, as well as, of course, the recovery rate and the rate at which people are falling ill. And this is called the contact rate as well. Okay. Another question which we ask is, will the disease die out or persist in the population? So dying out would mean that I is equal to 0. So under what happens when I is 0? Is I equals 0 a steady state of this system? And if you plug in I equals 0, you get a degenerate system. Everything is 0, right? And so basically I equals 0 is a entire line of steady states if you just look at the SI plane. And so bottom line is, SIR model, everything eventually dies out. There is no endemic steady state, or disease cannot persist in the population as per the SIR model. Oh gosh, I'm running low on time. Okay, so with this simple model, we could do some analysis as well. Just since R is just S plus I plus R is a conserved quantity, so the R equation is unnecessary. Remember, each time you have a conserved quantity, you get one reduction in dimension. That's used in so many places, right? So one way is here. So because R could always be obtained if you knew S and I. So, ds dt is this, di dt is this. So di ds, you can get an equation for this. Just integrate it and you get an equation for I. Okay. And let's see. Oh, right. So a question you could ask is, what will be the final state of the population after the infection has run its course? So once, I infinity is 0. In this model, as time goes to infinity, the number of infected goes to 0. So if you just look at this equation, look at I infinity on this side and S infinity, just solve it, you get that this is S infinity, okay, is just this quantity. Rho is A upon R, okay. And S infinity means the number of people at time infinity who never got infected. How many people catch the disease before it dies out? So I total is just I naught plus S naught. That was the initial population minus those who never caught the disease. Right? How severe will the epidemic be? So mathematically, what's the maximum number of infected? This is an equation on I. We can find the I max, and this is what I max is. Okay. At what value of, just differentiated with respect to S and set it equal to 0, and then you get I max. Okay. It happens when S is equal to A upon R, and this is okay. So now you can say, what is the maximum number of infected? Again, you need to know rho, which is A and R. You also need to know S naught. Okay. We saw this old quantity, our old friend back here, S naught, less than A upon R, no epidemic, S naught greater than A upon R, then there is an epidemic. So if you just bring everything to the left-hand side. So S naught R over A. If this is less than 1, then there's no epidemic. If this is greater than 1, then there is an epidemic. So this is a very famous quantity, which you have heard a lot in the previous few months, and that is R naught, S naught R upon A. If this is less than 1, then there is no epidemic. The number of infected would fall. If this is greater than 1, then the number of infected would rise. And all the control measures like quarantine, isolation, vaccination, medication, and so on, masking, are suggested to make this quantity less than 1, so that the number of infected starts falling. Okay, so initially a lot of work has been done. So you might have seen reports R naught equals 2.4, R naught equals 3.6. In China, it was even close to 4. We estimated it for Pakistan, it was around 2.4 back in June of 2020. So this is called the basic reproduction number, or the basic reproductive ratio. And it sort of is a threshold quantity which gives us the path of the disease. Okay. Okay. If R naught is greater than 1, then an epidemic would occur. Oh gosh. So R naught actually depends upon a few things, right? It does depend upon the disease. What's the recovery time, right? It depends upon S naught, R, and A. R is the contact rate. How frequently are infecteds running into susceptibles and making them sick, right? So that's the contact rate. It's also dependent upon the initial susceptible population, and it's dependent upon how long do you stay infected. So this is something I just did to show you that this is the simple SIR model. Oh, sorry, this R is equal to 0.3 and A is equal to sorry, which was it? So beta was R. So, and I took, this is just arbitrary, so I took A to be 25. So it's a very shortly lived disease. And this was just to show you something. And N is equal to 400. N is the, so initially there were 2 infecteds. I took I naught equals 2. So S naught was 398. And as you can see, the green curve is the infected population. So the infected population rises, and by it falls. There is an epidemic because the number of infecteds rose initially. In an SIR model, the number of infecteds will go to 0 by and by. That's just what we built into the model. Again, the same parameters, but now the initial number of susceptibles is 48. And as you can see, there is no epidemic. You had the initial number of, so you had the initial infecteds just fall down to 0. Here, you had an epidemic. Oh, sorry, my bad. So I did not take I naught to be 2. I naught was taken to be like 14. My bad. So here, the initial susceptibles were 400 minus 14, which is 386. Okay. And here, the initial susceptibles were 36. So the key point here was that the initial number of susceptibles decided whether or not you had an epidemic or your disease just died out monotonically. All right, so this is what we have covered. We can also fit data and estimate R naught. Okay, so usually it's not done with the infected but in principle you could do it if you had infected over time. That's the red dots. You could use an SIR model. That's the green curve right here. If there was an epidemic, and you could do a fit. How do you do it? There are many ways to do it. The most simple way is either use least squares, ordinary or generalized. So you need to understand your data, by the way. Whenever you do a fit, you need to make sure you understand data is always noisy, and you need to understand whether the noise, so OLS works when the noise is additive, and GLS works when the noise is multiplicative. So the more people that are reporting they are ill, or the more ills that are reported, the higher the false cases. That's a multiplicative noise in the data. So you have to understand your data to do this. There are other ways to do it, which are more fancy, like Markov chain, Monte Carlo, and so on. But the bottom line is you somehow find the parameters, or in our case, the contact rate in an SIR model by fitting data to the model. Okay. And this is what, by the way, a lot of estimations of R naught, that's how R naught was estimated by many people for COVID, as we will see. Stochastic, so you could have a Markov chain model. This is just where probabilities are specified. What is the probability that a susceptible will become infected over some small time period, delta t, and then you just set it up and roll a dice and see what happens. Okay, so that's a Markov chain model. As I said, it has been shown rigorously that in a large population limit, a Markov chain model converges to the deterministic SIR model. This is an analog of the SIR model, but in a stochastic setting. I will not do so one modification of a SIR model could be that once you recover, you're no longer immune, but after a delay, you can again become susceptible. And that's the so-called SIRS model. And this is the simplest model that allows for an endemic state, okay, where the disease persists in the population. Here's a run of an SIRS model with these parameters. And you can see that the green line is not going to zero. So there is always going to be some number of infected in the population. Okay. Okay. Again, that's another endemic state. You might also get oscillations before you reach the endemic state with the SIRS model. And this is a case in which there is the steady state is the disease-free state. Okay, so with an SIRS model, you can get either endemic state or a disease-free steady state. Okay, sorry I got lost, but so COVID transmission models. So I looked at COVID models, and you look at the major journal databases, and people did that. I did it on Google. You get like a few 100,000 hits, right? But if you type COVID transmission models, mathematical models of COVID transmission. So, but if you look at the major databases with journal articles, you get around 50,000 hits. There's a nice review paper I have in the references. It took these 50,000 papers, then took away the replications, took away the papers which had little math in it, and they came around 5,000 papers were on COVID have been published, and this was in early 2021. Okay, I think the number would have doubled by now, if anything. And then they did an analysis of 450 of those papers. Okay, so but here I just wanted to show you that a huge literature has sort of been developed around this COVID theme. Most early models were basically fits to exponentials or logistic curves, or you had statistical models which try to predict the numbers. That 14-day moving average model was very popular. Everybody was doing that, right? Then you had dynamic ODE models or PD models that were very useful in basically looking at efficacy of controls. These models were cited by a lot of public health authorities as the basis to implement social distancing, which reduced the contact rate, the rate at which I meets S and infects S, or impose a quarantine or isolate infecteds and so on. Okay. Okay. So ODE models is what we've been working on, and I will look at 3 ODE models and then a model which is an agent-based model, or it's kind of a stochastic model, okay, and see how disastrous that was, by the way. So you need to take into account dynamics of the disease. Now for COVID, important pathways were asymptomatic individuals. They're still, it's unclear that what fraction of COVID infected individuals shows no symptoms. You never know you got infected. And the various estimates range from 20 to 80%. So it's all over the place, right? You have initial models which were developed like in the early 2020 had to include quarantine and isolation because those were the only two control measures that could be taken, right? Quarantine, isolation, and social distancing. So those were what most early models were centered around. And then people started looking at, all right, once a vaccine does come in, what are the effects of vaccination? Remember, vaccines are not perfect, right? They don't prevent the disease all the time. You do fall ill. They might reduce substantially the disease mortality. You don't die from the disease, but and you don't fall ill that often. So unvaccinated people fall ill a lot and they become severely ill. Vaccinated people do fall ill sometimes, and most of the times they're not severe. And again, masking, social distancing, what were the effects of it? Another thing which we did actually was look at, it's been well established that comorbidities like high blood pressure, diabetes, and so on played a big role in high mortality due to COVID. Okay, so other people, including us, we tried to sort of factor that in. And then we tried to project the numbers. Okay, and that's the good, bad, and the ugly. How successful were these models? In the last 10 minutes, I'll try to give you a picture of that. The slow build-up was so you have some idea of what went into these models and where would they have failed. Okay. So this is a model developed by a group at Arizona State, and they take an SE. So this is a susceptible, this is a latent class, these are infected, asymptomatics, isolated, recovered, and dead. Okay, so they took the dead population and just put it in there. U are people who are unmasked, M are people who are masked. So this is an SIR model in a fancier version, right? Instead of just having susceptible, infected, and recovered, you now have a latent class, people who are infected but cannot transmit. And then you have asymptomatics, which was important for COVID. Isolated people, these people cannot transmit as much because they're probably not connected with other people. They can't run into susceptibles, right? The other thing they did was a very clever idea. They said, look, you know, the contact rate at which I is meeting S, at initially, there are no restrictions. People are running around, are dining in restaurants, going to the cinema and so on. So that's some fixed number, but then it decreases over time. And it decreases to some minimum value, okay? So there's some beta minimum, which is the minimum contact rate. As time goes on, this is a decreasing function. And let's see what happens. They did this analysis for Washington and New York, and this came out in April of 2020, and they had made projections. So the black line is the data they used, early April, right? That's the data they used. And they made projections. And they said, well, if 20% of the population is masked and there is no social distancing, beta or the contact rate is fixed, what would happen? And they predicted what, 30,000 deaths with no masks, and with if the masks were 80% effective right here, then that's where you would end up, which is around 15,000 deaths. Okay. Let's look at, this was the worst case scenario. This is the best case scenario, that 80% of the people were masked, and there was masks were 80% effective, and there was lots of social distancing. So beta was variable, right? The beta we saw. So beta was variable. So social distancing was in play, and the number of infected, number of deaths, sorry, would be around 1,000. Okay, by May 30th. This was the projection. They made a month and a half long projection. Well, yeah, sort of. So 2-month projection. And the actual deaths in Washington state, as of May, I should have written May 30th. This is exactly the day they ended their study. This was published in April. They made this projection end of March or very early April. And end of May, look at the numbers. So their best case scenario does come pretty close to what actually happened. Okay. And their estimates for New York were pretty neat too. So, but of course, they did a scenario analysis. Now, which one of this actually happened? Were 80% of the people masked? Maybe. Were the masks 80% effective? That's sort of iffy, right? But at least, even if this was the case, that half the people were masked and the masks were 50% effective, you still had around 1,100 people sort of, which was, 1,100 people falling ill. That's a decent estimate, right? Pretty close to what happened. And over 60 days. So it's okay. Then the same group did another model, this time for Nigeria. Okay. And they took a simpler model. It was susceptible, latent, symptomatic, asymptomatic, isolated, and recovered. Okay. That's the model they took. And they tried to see what would happen in Nigeria as a whole. And they did it over, say, 8 months, right? So this is 9, this is, actually 1 year. More than 1 year. And their best case scenario, that if the masks were 50% effective, which by the time they wrote this paper, which came out around June, I think, in 2020, their best case scenario predicted that around 120,000 people would be dead in Nigeria. The number of deaths in Nigeria after 1 year was 2,170. So even if social distancing was there, masks were there, 80% people were masked, and masks were 50% efficient, then their projection was saying that 140,000, close to 140, 150,000 people would die. And the worst case scenario was like 250,000 people would die, right? And the number of deaths was 2,117. So for New York, for Washington, it was a pretty neat result. And for Nigeria, it was bad. And two reasons immediately come to mind. One is the time frame. This is a year-long projection. And the virus did a number of tricks on humanity in that 1 year, right? So that's one problem. The other problem is that this is for an entire country, which is a very heterogeneous population. There are urban centers, rural centers, sparse populations, dense populations, and you just bundle them all together. Whereas this was for Washington state, again, not as good as if they would have done it for, say, Seattle and rural Washington separately, but better than taking Nigeria as a whole. Okay, so you have to account for smaller times, better predictions, and again, the more homogeneous the population, you get a better result. So that's that. Then we come to our model. I have like 2-3 minutes in which I'll finish up. So please be patient. I'm not going to run over. Okay. Again, this was an SEIR type model with asymptomatic and quarantine. We included quarantine in our compartment. We also included this medicated and isolated population. So if you're, this is by this time that remdesivir was in the market by the time we got to this paper. And we wanted to see what can we say about Pakistan. Okay, so first of all, I didn't do the good things. We were able to predict when the peak would come. We did this paper in early June, and we predicted that if the government got serious, then by early July, first week of July, we'd hit the peak. And the peak did come in very, very early July. The maximum number of infected during the first wave of COVID, if you remember. But, that was the good thing. Let me show you the bad thing. What was our best result? Our best result was right here, this green line. So, you know, you're masking, you're socially distancing, you have a good quarantine going. There's a chat question. I'll get to that. Can you just remind me once I'm done, why did the COVID death rate remain low in Pakistan, right? So that's, there are some thoughts I have on that, by the way. So we predicted 150,000 deaths in the best case scenario. A strict lockdown, contact rate is reduced to 80% of what it was before before social distancing measures were in place. And well, December 28th, that was our prediction, right? What is the actual deaths 6 months from when we started? The actual deaths were 10,000. We had predicted 150,000. That was, if everything was done very well by the government, right? A bad estimate. Okay. As I said, there were good things which I didn't show, and that was the peak which we were able to predict neatly. Again, the peak was closer to when we started. So one theme that comes up again and again is that these models can only predict for a short amount of time, maybe a month, a maximum of 2 months, because the virus is also changing. And you've had people's behaviors change, the virus changes, it mutates, which nobody knew it would that quickly, right? The last, and so, you know, we were embarrassed, but we weren't as embarrassed as these guys. This is a model which predicted a catastrophe for human beings, millions of deaths. This was by Imperial College London, and they used, I won't go into the details. If you're interested and you know something, then they used an agent-based model. They used some kind of a stochastic model. And just look at this one column. Okay, forget everything. So there's some population, they said if nothing was done, then this many people would die. If social distancing measures were implemented, reasonable social distancing measures, then this is what would happen. And this is if the country went into complete lockdown, nobody moves. If you're home, you stay at home. This is, of course, not what happened. This is, again, not what happened. This is if nothing was done. Countries did do something. This is the column to look at. And look at the overestimates. 4,000%, 1,600%, okay? I mean, we overestimated it too, but my God, right? And so what happened was that the Imperial College did the study, they published it, and by the way, it's in Nature. Nature, the big Nature, not scientific reports or anything, but Nature, right? So Nature did publish this. Then the Swedes took over, and the Swedes said, you know what, Imperial College is a very good place. We are impressed by them. So we will try to sell this to our people, that we will make models based on their models. The Swedish model is basically, here you go. If you had a moderate kind of mitigation, then this is what would happen. 800,000 deaths. And here's where the actual mortality curve of Sweden was. Okay. So this is very bad, right? And then there's a lot of backlash in the British Parliament. This is the team leading this was led by a physicist. Hence my jibe at the physicists do wonderful work, but sometimes, you know, you got to talk to the epidemiologists. All right. So very quickly, in 1 minute, sorry for going over, I think it's 5. What are the reasons that these models failed to predict? Again, maybe all pathways were not accounted for. There was a lot of mobility issues. For example, India saw a huge outbreak at some point, because what they did was they took everyone who was working in the big cities where they probably came in contact with travelers from other countries and forced them to go home. I mean, why they did that is just beyond anybody's imagination, right? So they basically sent infected people all around the country to infect others. So mobility needs to be taken into account. Pakistan has low mobility. So to answer the question that was raised, Pakistani population is not very mobile, right? People don't travel large distances. a bulk of people do not. Okay. Um, the virus also disagreed with these models. The virus said, you know what, I'm going to mutate. So there. So the virus mutated, people became lax. There was a second wave, then there was the Delta variant, and now we have the Omicron variant. Nobody modeled that, right? Heterogeneity was not accounted for in many of these models. So as I said, all the models I showed you basically had the population well mixed. Populations are not well mixed. Karachi would have a higher incidence of COVID. Somewhere in the interior of Sindh, especially the very rural areas, would have a lower incidence because the number of infecteds there, it would be hard to find the patient zero there, right? Usually. And one of the big things was this thing called non-identifiability in the model. So the number of cases which we tried to fit and the data to and project from there on, and the number of actual, the number of reported infecteds and the number of actual cases are never the same, right? The number of infected are those that show up, are tested, and are then written down as infected. There are many, many people who are sick, infectious, and don't report. They don't go to the doctor. They and so on. So this case infection ratio is a very variable quantity. For I think the flu, it's a very small number because flu is well reported in the US at least. It's like a 0.01, 1 upon 100. And for other diseases, it's as big as half. So half people don't report, right? So, and with a new disease like COVID, we had no idea. So many times the fit that was done to estimate R naught or the contact rate, they were bad fits. So that was perhaps another reason. So was this all in vain? Should we have, well, first of all, I need to eat. So I need to make models and sell them, right? But other than that, I think qualitative results were good. Is the disease going to go up? And when would it go up? So timelines were, at least in terms of when would you reach a peak, they were decently captured many times. Some models did make quantitatively accurate predictions, as you saw with the earlier Arizona state model for Washington state. And most importantly, masking, social distancing, these models really brought home the message to the public, look, if you don't do this, then there's disaster. So they have some value, but one has to be careful with these models. And here is the bottom line, that the modelers or the models do not make the timeline of the disease, the virus makes the timeline, okay? So you have to understand the virus better. Thank you. Actually, this is a better quote than the guy scratching.
Thank you, Adnan. You mentioned Fauci, who remained in the news for regarding to virus and spreading a lot of, I think, controversy in United States. Isn't it the same Fauci?
It's the same Fauci, and I think he's an epidemiologist. He's a bit of a politician as well. He survived Trump and still surviving, right? But he was saying the right things. I mean, people needed to mask, people needed to socially distance. It just became a stupid issue there because, you know, the virus dictates the timeline. I think stupidity also dictates the timeline of a disease.
Yeah, in most of the countries, particularly in Brazil, particularly. Okay.
Yeah.
Thank you very much for the wonderful talk. And there is one question by Nakib, which is this is a surprising mystery whether Rouhaniyat is working very well in Pakistan. And there are very less number of death cases reported due to COVID in comparison with other countries, India.
Right.
And
so again, one of the factors could be there are two. I suspect that mobility is a big issue. Pakistani population as a whole is not a very mobile population. People don't travel great distances. I mean, in the cities they might, but that's not the bulk of the population, right? And secondly, Pakistan has a huge youth bulge, right? So young people 16 to 25 make up like 60% or something of the population. It's a huge percentage. I mean, I don't know whether it's that exactly, but it's a huge percentage. It's like several times that of no Thanksgiving here. Oh, no Thanksgiving here. Yes, but there was Eid and Bakra Eid and so on. So Thanksgiving, that's right. But yeah, but and as Mohsin pointed out, people don't travel that much in the US and other countries where this became a big issue. There was lots of travel. In India, they forced people to travel. So there you go. So those are two reasons, and young people were less prone to severe infections, and which means they probably didn't show up and report the disease. So that's another thing, right? So that's my guess, but maybe it's Rouhaniyat at play as well. Who knows?
And who knows? Okay. And what about taking these population different phases into account of changing some new parameter of the age of the receptors in doing further modification in the SIR model?
Right, right. So, I mean, you could have a continuous age structure in the population by turning it into a PDE, right? Or you could have three separate age groups, very young, middle-aged, old, right? Or four age groups. So you could have a system of ODEs, an SIR model for each of these groups. And then, so that's one way. And if you really want a continuous age structure, then you could just turn it into a PD. The problem is that the complexity of the model increases and analysis becomes harder. And actually, I've been really thinking, so the model they used for predicting weather, it's got like more than 100 equations from physics and all sorts of different fields. Okay. And nobody can solve those equations or do qualitative analysis. They can crunch out numbers. So maybe it is time to move towards a computational kind of epidemiology where you have more realistic models. Just because you can't solve things and get nice expressions, that may not be the reason to stop us from making more realistic models. So I don't know, that's a thought actually.
Yeah, it's very interesting, Adnan. It is always pleasure to listen to you when you are explaining particularly the modeling aspects. Any questions from the audience? Anyone? Okay, if this is the case, let us thank the speaker once again. Thank you, Adnan, and looking forward for more similar kind of talks. And thank you, everyone. And that is the last talk of the year. And we will resume this Turn Converse Spirited Seminar series in the next year in the new semester with the new spirit. And till then, stay safe.
Thank you for tolerating me for an hour and change.
Thank you. Thank you, everyone. Thank you. Bye-bye. Take care.